So let's talk about traumatic arrest and our approach to traumatic arrest. One of the most important things when it comes to our approach to traumatic arrest is our mindset. We need to consider this patient to be a candidate for resuscitation. No more trauma dead is trauma dead. Does traumatic arrest have a low incidence of survival? Yes. But so does medical arrest as far as all comers go. So we need to stop treating traumatic arrest as this anomaly of low survival that we're not accustomed to. With both medical arrest and traumatic arrest, it's about patient selection and who is a candidate for resuscitation. So with arrest, we're going to follow either a medical pathway or a traumatic pathway. With a medical pathway, we're going to provide quality compressions and timely defibrillation. Neither one of those are appropriate for a trauma pathway. Chest compressions require two things: an intact circulatory system and adequate circulating blood volume within that circulatory system. Without those two things being present, chest compressions are not only ineffective, but they could end up exsanguinating the patient. With defibrillation, it's not necessarily inappropriate, it's just unlikely to be indicated because traumatic arrest rarely presents with or leads to shockable rhythm. So traumatic arrest is about removing obstacles to resuscitation. And this is where your patient selection comes into play. So we're not talking about obstacles that are injuries incompatible with life. We're talking about hypovolemia, oxygen impairment, tension pneumothorax, and tamponade, cardiac tamponade. Hypovolemia is present in about half of traumatic arrests. The other three are each present in somewhere between 10 to 13% of traumatic arrests. Those four things together are your hot mnemonic, and they identify conditions that we want to correct in order to facilitate a successful resuscitation. And that begins with hemorrhage control and replacement of volume, preferably blood. Then we want to secure that airway through any means necessary: an endotracheal tube, surgical airway, whatever provides a good, secure pathway to the lungs. After that, we would consider bilateral needle decompression or bilateral finger thoracostomy to correct tension pneumothorax. And then after that, we would consider pericardiocentesis to correct cardiac tamponade. And circling back around to compressions real quick, I just want to make sure it's understood that it's not that you never performed compressions in traumatic arrest. They are de-emphasized in traumatic arrest as they are unlikely to be an effective early intervention. Follow your local protocols.